So welcome everyone to another session of our exciting series of webinar this year. And it gives me a distinct pleasure to introduce our speaker for today, Dr. Sheetal Parekh, who is a pediatric sports medicine specialist at Cincinnati Children's Hospital, professor of orthopedic surgery. And when we started discussing, my big thing was that as it's not just for our patients alone, but for ourselves, we we are all trying to be more physically active, and one of the commonest things that we come across is a sports injury, and how do we address those, or what needs to be done, and this is where he came up with an amazing title out here, Managing Sports Injuries in Primary Care from Sideline to Clinic. And Dr. Indranil Kushare is, he may be able to join us soon. He's a pediatric orthopedic surgeon from Texas Children's Hospital at Baylor College of Medicine, who will be able to moderate the session in the end. So welcome both, and welcome Dr. Parekh, and we look forward to your presentation. Thank you.
Thank you, Amit. Thank you, Satish, for the invitation. Can you see the slides, and can you hear me okay?
Yep.
Okay.
If you want to put them in the presenter mode, we can just see the whole thing.
Better. Yeah.
And what do I do there?
Just go down, and if you see those small little flags.
Slideshow. Go to slideshow, please, on the top. Yeah. It's where the home tab is in the same row. You see slideshow.
That's what I pressed, and that is where I am right now from the slideshow. Okay. But maybe I can stop that and can go back. Hold on 1 minute.
Yeah, that looks little.
Yeah, I think that's.
It went back to the same thing again.
Okay, so do you think this is better? Then I can just, it's not a slideshow.
There is also a small icon, Dr. Parekh. If you go down all the way on the right-hand side, there are some icons. Yeah, there you go. Could you press on that slideshow? Is that what you did just now?
Yeah.
Okay. So,
So you're not able to see the slides, or is it not?
We are able to see the slides, but not like a slideshow. It's like, when you're making slides, you see the view. That's what we are seeing here. Yeah.
Okay. So let me just come back and let me just stop sharing it for now. Hold on 1 minute. Okay. Is there any difference now?
No, we don't.
Can't see the slides now. So
okay, you have to share the screen. Yeah.
Okay.
Okay. Yeah. Perfect.
Are you able to see everything now?
Yes.
Okay. Perfect. All right. So we're going to talk about the managing sports injuries in primary care. I'm thankful to both Amit and Satish for the invitation. Just make sure I can move the slides. Okay, I don't have anything to disclose, and I need to acknowledge my partners, Dr. Wall and Kate Burns, who are Dr. Wall is orthopedic surgeon, and Kate Burns is the primary sports medicine doc, and we have shared some of the slides between the group. We're going to talk about epidemiology, some acute injuries, when to transfer the patient to the ED, some chronic and overuse injuries, and when to refer the patient to orthopedics and sports, and some prevention topics at the end. We'll focus on the adolescents. So there is a wide variation in education when it comes to sports medicine. Patients who present to primary care physicians with MSK complaints Often, they are more often than patients with respiratory tract infections or hypertension or diabetes. And despite this, the MSK uh, instructions for internal medicine resident is less than 1% of their total didactic and clinical education time. So there is a big disparity between 20 to 30% volume that primary care would see for the MSK injuries and the total amount of time that is done in education. And there are a lot of curriculum guidelines, and in spite of that, we still see that it's underrepresented. If you look at the medicine overall in the medical school curriculum, only 20 out of 136 schools actually had an MSK medicine program where they would do a clerkship. And out of those schools, the amount of time that someone would spend is only 2 weeks. So you can imagine that in the entire medical school, you're only spending 2 weeks for MSK medicine, which includes orthopedic injuries and sports injuries. Then that's significantly less. And the same is for residents. The residency requirement is about 100 hours, and it has increased to 200 hours, which is 2 months. But out of 2 months out of 3 years in MSK medicine is still too less. There are a lot of resources. I'm going to put this slide at the end as well, but there are books that are available for reading. Orthobullets is something which is frequently used by orthopedic surgeons for board preparations as well, because everything is point-wise, and anyone can join for free, and non-orthopedic surgeons can't make any changes or edit anything, but you can still view the orthobullets. I think it's a great resource. Same with viewmedi.com. You can join ViewMedi as well. There are videos of anatomy, how to do a physical examination of a joint, how to interpret X-rays and MRI. So a lot of useful information. The Ortho Info, which is by the Academy, AAOS, is for patient education, so you can provide those resources for patients. And then the National Council of Youth Sports has partnered with AOSSM to create this Stop Injury program, which is sports trauma overuse prevention. And if you go to their website, they have a list of all these topics, and you can choose topics, and it will give you a quick, cheap sheet with a lot of good, useful information, from concussion to sports nutrition, lower back pain, and all topics. So these are good resources that you can use in your clinical practice. The importance of sports cannot be underestimated. The adolescents, they rank the failure to make a team worse than failure to pass a grade in school, separation from parents, or death of a close friend. That's how important the adolescents rank the sports as. And the benefits of sports include physical, emotional, social, economic, and then all sports are not equal. So sports is classified based on the strenuousness, which is based on dynamic or endurance, and then static, which is strength. And then it's also classified based on contact. And a lot of injuries or conditions are based on what kind of sports you're involved in. So if you take this, for example, the bottom left, which includes cricket and billiards, they are low in strength and low in endurance. And if you look at the bottom right, running or long distance is very high in endurance, low on strength. And these are the typical sports where you can get overuse syndromes or overuse conditions. And if you look at the top left, which is more in strength, where you can get acute injuries from weightlifting and water skiing. So it depends what kind of sports you're involved with. When it comes to contact injuries, there are certain sports where you routinely hit or collide with others. And in those cases, concussion and contact injuries are common, versus non-contact injuries like swimming and tennis, overuse injuries are more common. There is an epidemiology of sports injuries, or an epidemic of sports injuries, I should say. If you look at the CDC or the government website, there are more than 10,000 ED visits every day in the US related to sports. 1 in every 5 ED visits are related to sports. Children less than 15 years account for 40% of the visits, and significant injuries in school setting. And it makes it to the headlines of various newspapers like the San Francisco Chronicle, New York Times, where sports injuries to the young are up sharply. And then there are books written about it, and this just shows the obsession of youth sports in US. If you look at the type of injuries now, luckily, most common injuries are sprains and strains, which can be treated in office. They don't need to be referred to orthopedics. They don't need to go to the ED. If you see them in the office, you can treat them. We'll go over just some basic treatment principles. Second common, again, is contusions, abrasions, which can also be treated in office. And then comes the fractures, where referral to orthopedic surgeons probably would be required. If you look at the common sports, here are the list of the 8 common sports, which includes bike, basketball, football, playground equipment, soccer, trampoline, and combine this 8 sports, they account for 2.2 million MSK injuries at a cost of 33 billion. So significant impact of sports as far as MSK medicine is concerned. When it comes to children, we all know that they are not small adults. They have open growth plates, which have to be accounted for. And that also leads to some unique issues that the kids can face because the growth plate is the weakest structure compared to the ligaments and the capsule around the joint. So there are more growth plate injuries compared to what you would see like strains and sprains in adults. If you look at the Salter-Harris classification, which is the classification used for physeal injuries, type 1 is when there is complete separation of the physes. Type 2 is the one which is most common. Type 3 and 4 are the ones that require surgery because it extends into the joint. And you can forget type 5 for now since it's diagnosis in hindsight. But these classification system is important because it kind of dictates a treatment as well. The important point about knowing the growth plates around the joint is that even if the fracture is not seen on the X-ray, there could still be a fracture because the growth plate is a cartilaginous structure. It's seen like a dark line on the X-ray. So if there is a fracture through it, you may not see it like you would see a fracture in adults. So you can still have a fracture even though it may not be seen on an X-ray. And a lot of times patients, especially families, would say, is it a break or a crack or is it a fracture or completely broken? So it all means the same. When there is fracture and bleeding in the same part of the limb, it is technically an open fracture, even if you don't see a connection between them. For example, this patient had this really small wound where, when squeezed, you would have a little bit of blood come out of it. This is considered to be an open fracture, and these fractures need to be referred. Whenever I put this red star is a referral to the ED. Open fractures need to be treated a little bit on the urgent basis. It's better to transfer them to an ED. Again, if there is a deformity and if you can't reduce it in your setting, it's better to transfer them. When you transfer them, make sure they're in a comfortable position. Typical position for splinting any deformity is position of comfort, about 30 to 40 degrees of flexion of the elbow or the knee. And these patients have to be transferred to the ED. And if you keep the arm straight, you can just imagine the neurovascular structures would be pinching on this spike, metaphyseal spike, and you can have some compromise there. So it's better to just keep them in a little bit more functional position. Compartment syndrome is also an emergency, needs to be sent to the ED. The 5 Ps in adults that we typically know about when it comes to compartment syndrome, by the time these symptoms appear, it's already too late for a fasciotomy. So I don't think that the 5 Ps is what we need to go by. Instead, you should use the 3 As, which is common. It's anxiety, agitation, and analgesic need. If there is increase in analgesic need, then there is a sign that the patient may have impending compartment syndrome. A lot of time I've seen some mistakes in the way splints are placed. Either they are placed too tight, the A-strap is wrapped too tight, as seen in this patient. You can see the forearm is actually the size of the arm and vice versa. There are some urgent fractures. You can refer them to either the ED or the orthopedic surgeon based on what time of the day you are seeing these patients, but they may appear to be undisplaced like a femoral neck fracture or a talar neck fracture, but they need to be fixed. They need to be done on an urgent basis. Same with scaphoid fracture. You need to be a little bit more aggressive because there is high rate of AVN and non-union with these injuries. So it's better to just make sure that you identify these injuries and refer them. Let's look at this case where a helmet-to-helmet injury happened, no loss of consciousness, but immediate headache, which then resolved, but the patient wanted to be cleared. Now, one thing we need to know is that this is a concussion, and then a concussion is treated with some guidelines, and there are sport concussion assessment tools, CAT tools. I won't go into details for this, but they can lead to some prolonged symptoms that are return to play criteria. But when you see a patient with concussion, whether it's sideline or in your office, it's better to refer these patients to sports medicine. The reason is that they are experts in dealing with this concussion. They would follow this patient. It's a stepwise progression. It's not like one time you see the patient, they're doing fine, you can release them. They need to have a follow-up. They need to have some monitoring as well. So it's better to have a patient with concussion referred. When you see patients with joint hypermobility, or they have, Beighton score of say 9 out of 9 or 8 out of 9, does not mean that they have EDS. Hyperlaxity is common, or hypermobility is common in kids because of increased collagen 1. As they age, they grow. There is some stiffness that naturally comes into their joints, and 5% of the population is hypermobile as per Beighton criteria. So these are not EDS patients, but I've seen a lot of patients being referred from primary care offices saying that, or the patient would say they have been given a diagnosis of EDS, and that probably should be a diagnosis given by genetics or rheumatology, but not primary care. Let's look at some acute injuries. Patellar dislocation, it's almost always lateral, is non-contact, and most of them have spontaneous reduction. If you see something which is not reduced and they show up in your office with a dislocated patella, you just need to make them relax, maybe give some medication to relax them, and then you extend the knee, and the patella would reduce like seen here. You extend it slowly and the patella reduces. So it's not a maneuver like a shoulder that you need to pull on it or push on it. It's just a matter of getting the knee extended, and it would reduce. So whether it's on the sideline or in the office, you can reduce the patella easily. There is an entity called habitual dislocation, where the patella dislocates every time the knee is getting into flexion. This is called habitual dislocation. You can also have permanent dislocation, where the patella stays dislocated. You can get voluntary dislocation, where the patella can be dislocated just by contraction of the quads. And you can see this is habitual dislocation in extension, or a J sign. So different ways of how the patella can dislocate. Not all of them would need surgery, but definitely need a referral to a sports specialist if it's symptomatic. The most sensitive sign when you're examining the patella is trying to push the patella out laterally, and the patient would have significant anxiety, and that's very sensitive test for instability. So if you're not really sure what happened, you can try to push the patella out, and the patient may not like it, and that's a sign that it's unstable. Most important stabilizing structure for a patella is the MPFL, or the medial patellofemoral ligament, which prevents the patella from shifting laterally. For a first-time dislocation, you can use an immobilizer till the patient's pain and swelling subsides, and then physical therapy can be started. Typical time to go back and do sports is around 6 weeks, and depending on how many risk factors they have, anywhere from 30 to 70% would not have further dislocation. If there is an osteochondral fracture, or if there is recurrent dislocation, then surgery is required. This is an example of an osteochondral fracture that is treated with internal fixation, and this is how an MPFL reconstruction is done. Use a tunnel, put a gracilis allograft through it. You can use semitendinosus allograft. You can use autograft, quad tendon autograft, various options of what you can use to reconstruct it. And it's a fun surgery. One of my favorite surgeries, one of the surgeries that I do most often, is the MPFL reconstruction. About meniscus injuries, the old school of thought is that you can excise if it's torn, and the patients do very well. The issue is that with long-term results, we found out that the amount of arthritis that your knee has is proportional to the amount of excision of the meniscus. So now the idea is to save it. So various type of tears, you would see it on MRI reports: longitudinal, radial, flap tears, complex tears. One thing we want to make sure that we understand is that in children, there is vascularity in the meniscus, which shows up as grade 1 and 2 signals on the MRI. And frequently, the radiologists, especially if they're not used to reading MRI in children, would call these as meniscus tears. Now, if they are grade 1 and 2 tears, those are not real meniscus tears. And so you need to just make sure the patient understands that as well. And we see a lot of patients being referred for meniscus tear when they're actually grade 1 and 2 signals. The real tears actually extend onto the surface of the meniscus like this. They are grade 3 tears. Those are real, but grade 1 and grade 2 tears, they do not need to be referred. They can be treated just like knee pain or a meniscus contusion. Grade 3 tears do require surgery if they're large enough or if they're unstable. So they are better to be referred to an orthopedic surgeon, and then they need to be repaired if it's unstable. Just a quick slide on discoid meniscus. It's congenital. It presents as either visible or audible popping in a very young child. You don't need an MRI on that child unless there are more symptoms than just occasional clicking or popping. If they have tear, then they would have more swelling, more pain, a limp. But discoid meniscus can be either a complete discoid, which is the one on the right side, compare it to the medial meniscus. See how the lateral meniscus is shaped like a disc, and that's why it's called a discoid meniscus. And treatment, we sculpt it, we make sure that it has a proper shape, even though it's, the underlying, it's made up of collagen, which is not regular collagen, it's irregular collagen arrangement. So the meniscus is never normal, but you still make it look normal so it doesn't get caught into the joint. And then if it's unstable, you have to repair it as well. As far as ACL injury, we all know that the ACL tears are on the rise. Younger and younger patients present with ACL tears. These are 5 and 6 year old patients, and I've treated 6-year-old with ACL tears as well. Here's a typical example, a case where a 16-year-old female player was making a hard cut, wearing cleats on artificial grass and no players around her. And then she twisted, felt a pop, and had immediate knee swelling and stiffness. Very, very typical scenario for an ACL tear. Presentation, the injury is usually non-contact, like you saw in the case. The patients would frequently say they heard a pop or felt a pop, unable to bear weight, immediate swelling. The knee then feels loose, and they have a Lockman test, which is done like shown here. It's compared to the opposite side, and then a drawer test done at 90 degrees and compared to the opposite side as well. And if they have a little bit more excursion on the involved side, that just suggests insufficiency of the ACL. That brings us to a next point of when should we get MRI for knees. If you have a traumatic hemarthrosis, 80% of the time, it's a surgical lesion, either meniscus tear, ligament injury, or a cartilage injury. So if you have not a focal swelling on one side, that could be an MCL sprain if it's on the inside, or it could be a contusion if it's on one area. But when the entire knee is swollen, it's blood in the joint, it's traumatic hemarthrosis, then an MRI is recommended. However, I would always recommend getting an X-ray first to look at the shape of the joint, to look for any fractures, and it overall gives us a better sense of how the joint is rather than an MRI. And the other indication for MRI is if you have tried conservative treatment and the patient is still symptomatic, then an MRI would be helpful. For ACL, a brace is not the best option. I know a lot of physicians, even in our town, would brace them, rehab them, just because they don't want to operate on a kid with open growth plates. So they will try and delay the surgery. However, the best treatment option is to fix it at whatever age they present, because delay causes more meniscus tears and condyle injuries. So this is how we do. The one on the right side is how we do it in kids. We do an epiphysis to epiphysis fixation so that we don't cross the metaphysis. If you do an adult type procedure, which is on the left, it's not a great option because it's going to tether the growth and lead to growth disturbances. This is an example of how an ACL tear is treated in a young child. This is a torn ACL remnant. We are using a shaver here. This is arthroscopy of the knee joint, putting a camera inside, and then doing the surgery, which is arthroscopic assisted. So we're saying this is a remnant of the ACL, which is not very functional. Here we are using hamstring tendon for this patient. We're harvesting the hamstring tendon. We harvest both the gracilis and the CME and prepare the tendons on the back table, and a quadruple graft is going to make for the ACL. We do an outside tunnel drilling under fluoroscopy and arthroscopic control to make sure we are in the right spot. You can see we are below the level of the physis. We check with the scope and make sure we are in the footprint of the ACL. And similarly, on the tibial tunnel, we are using a jig, and we make sure that we drill into the epiphysis so that we don't damage the physis underneath. Once we have the guide pins placed for the tunnels, we would drill on those guide pins, create a little bit bigger tunnels so that the graft can pass in those tunnels, and then we would fix it. So this is making the tunnels both for the femur and the tibia. Then we pass the graft. This is a looping wire that is used to pass the graft. And then the graft is fixed on one side with a button and a screw on the other side. You're seeing the screw being inserted onto the tibial side, and you see final ACL. So that's how an ACL reconstruction is done in short. Tibial spine fracture is an equivalent of an ACL avulsion. Peak age 8 to 14 years. The tibial eminence is weaker than the ACL. The treatment here is to stabilize the fracture. So you can see the tibial eminence fracture or the tibial spine fracture is best seen on a lateral X-ray. You can see that piece which is pulled up. If you allow it to heal like this, it would lead to impingement and instability of the joints, so it's better to fix it. We use a screw. You can also use sutures to fix it. This is an example of how the tibial spine surgery is done. Again, arthroscopic surgery, ACL avulsion. You can see that this is a fracture bed. We are using a shaver to clean up the debris in the fracture, using a suture around the meniscus to pull it out of the fracture site so that it doesn't get trapped. This is a K-wire that we use to tentatively reduce the fracture and check our reduction on the fluoroscopic images to make sure we are happy with the reduction. Once we are happy with the reduction, we put another wire, and then we put a screw on top of it along with a washer, which compresses the piece, and that leads to stabilization of the fracture. And here is the washer, and here is final tightening of the screw. And then you have to check and make sure the screw doesn't impinge against the notch. So we want to make sure we check motion, check the stability, and here is the final fixation with one screw. And that would make the fracture heal in a good position and restore the stability of the joint. Next is ankle sprain. It's the most common sports injury, and it could be treated in the office. It's usually caused by an inversion injury. There is some swelling and pain on the lateral aspect of the ankle because the most common ligaments that are involved are the lateral ligaments, which are also called, it's also called a low ankle sprain, compared to a high ankle sprain, which happens around this area where there is syndesmosis. The anatomy, there is distal fibular physis, and then there are two ligaments which are commonly sprained, the TFL and the CFL, which are under the group of lateral ligaments. So if you see someone who has tenderness over the fibula, then it's a Salter-Harris fracture. Salter-Harris 1 fracture. And if you see someone who has tenderness over the lower aspect of the fibula or below the level of the bone, then it's over the lateral ligaments, and that is a typical ankle sprain, which is commonly seen in the adolescents. Treatment, you can use a brace of your choice. I like to use the air cast, but we also have stirrup brace, sometimes a boot if the patient needs a little bit more protection. The RICE principle is rest, ice, compression, elevation, then brace and crutches till the patient is able to bear weight without a limp, and then physical therapy if the patient have more than 2 sprains in a year. Not every patient needs physical therapy. And return to activities when the patient is able to single leg hop without pain, they can get back to activities. Avulsion fractures of the pelvis. So this is an example of a 14-year-old male who was kicking the soccer ball after school, felt a painful pop in front of his right hip, can walk, but it hurts. And what you can see here is this. It's an anterior superior iliac spine avulsion. That is where the sartorius is attached. Now, you see this in adolescent because there are open physis or open apophysis in this area. If you have a similar injury in an adult, it would be a strain of the muscle. So an avulsion fracture in adolescent is same as a strain in an adult, and that's how it's treated. If you look at this one, where is the fracture? It's just like spotting the differences. Can you spot the difference looking at left and right side? And here you can see it's the ischial tuberosity fracture, that is where the hamstrings attach. Another example, what is a fracture here? You can see it's on here, it's anterior inferior iliac spine where the rectus attaches. So you treat it like a strain, rehab principles of rise and sets, physical therapy, return to sports, usually around 6 weeks, and surgery is very rare. Typically, if surgery is needed, is for hamstring avulsion, which is pulled off significantly more in someone who is a soccer player or uses his hamstrings quite a bit to kick a ball. The last is shoulder dislocation, and there are some crazy things which leads to dislocation. A lot of times it's, trampoline. This is a trampoline injury, and not only jumping on the trampoline, but one person jumping on the other one, then that can lead to a dislocation, of course. And when you have a typical dislocation that needs reduction under sedation, so that needs to be sent to the emergency department. Most common dislocation direction is anterior inferior, and you can see the glenoid is there, the humeral head is dislocated inferiorly, and this is after reduction when it's back into proper position. When you have an anterior dislocation, the most common tear is what is called a Bankart tear, depending based on who described it, was Bankart. In this age group, in patients who are less than 20 years age, the recurrent dislocation rate after a first dislocation is significantly high, about 85%. And then that's why we recommend surgical treatment for younger patients. If they have anterior dislocation, then we have to do an anterior labral repair. This is an example of a examination under anesthesia. And they can also have posterior instability, typically seen in those who are doing bench pressing, wrestling, weightlifting, and they can have posterior labral tears. This is how we treat the shoulder dislocation or labral tear. You can see this is a scope placed from the backside of the joint. Looking towards the front, you're looking at the anterior labrum and the Bankart tear. This is a shaver that's cleaning up the tear. Then you can, we use an instrument called a suture lasso, pass it around the capsule and the labrum, and then pass a suture around the labrum. And that is what is shown here. You can see the bleeding from underneath because it's a torn structure. And then you pass the suture from another portal, you grasp the suture, pull it out, and you thread it around an anchor. And that anchor is what we would position in the glenoid or in the bone, and that would reattach the labrum back to the glenoid. This is creating a hole for the anchor using a drill bit. Once we create a hole, then we would tension these structures, the capsule and the labrum, and this is the anchor that's coming in with the sutures attached to it, and that is impacted in position. And once the anchor is in position, we cut the remaining sutures, and that is completion of one anchor. And typically for a Bankart tear, you will use 3 anchors, depending on how big the tear is, but 3 is a minimum number of anchors that we use to repair a shoulder dislocation. Next, we'll come to overuse injuries once we are done with the acute injuries. And most of these injuries can be treated in office. They don't need to be referred. We'll first look at the anterior knee pain. It's also called headache of the knee. Assume the role of a knee psychiatrist. It's so common because the fastest growing physes are around the knee, and there are influence of the hormones on the physes. So it's very common to see adolescent females with knee pain. In younger kids, it can be growing pain. There are a lot of other reasons, but most of them are benign. We need to ask a few questions. Does it wake them up at night? If there is swelling, if there is morning stiffness or mechanical symptoms. If it's yes, then we need to investigate further. Otherwise, we can just treat it without any further MRI or further imaging studies. When the patient says my knee dislocated, it means that the kneecap dislocated. The knee does not dislocate that simple. It's not that easy to dislocate a knee. It's usually a very severe injury. So a knee dislocation patient would not come to your clinic just walking saying that, oh, my knee dislocated. Those patients would not be able to bear weight. It's a multiligamentous injury. So when the patient says it dislocated, that means the kneecap dislocated, and those patients can continue to walk. When they say my knee cracks, it means nothing. Okay? Knee cracks is like every patient that I see would, not every, but a lot of patients that I see would have this knee cracking, knee popping. It in the crepitus can be a sign of some cartilage issues, but it could also be because of weakness of the quads. And a lot of joints can pop even without having any pathology. So, that symptom doesn't mean too much to me. But what we do want to make sure is that a patient who has an anterior knee pain has a good hip examination, because what is missed most often is a skiffy, and the pain in the hip can radiate down to the knee and towards the thigh, and the patient may only complain of knee pain. But when you see this patient, you need to make sure that you examine the hip in a patient with knee pain. They would have some tenderness around the groin. They would have a positive log roll test. That means when you log roll the leg, they would have pain. You need to examine the gait. They may have a limp, or they may walk with their leg externally rotated, like shown in the middle finger, that middle figure, that the leg is externally rotated. And then when you look at the x-rays, you can see the slip of the femoral epiphysis. That is what the skiffy is. Now, these patients need to be urgently seen in orthopedic clinic or need to be seen in the ED. Because this needs to be fixed. We don't know which next step would cause the head to completely fall off, leading to AVN, and you have no good solution for an AVN of a hip in this age group. Other causes of knee pain is this Sinding-Larsen-Johansson long name for jumper's knee, which is tenderness over the inferior pole of the patella. And Osgood is also a common cause of pain. You see a knot on the tibial tubercle aspect. If you look at a lateral x-ray, you might see fragmentation. It is not necessary to get an x-ray. And both these conditions, they present with anterior knee pain with running, jumping, climbing, squatting, kneeling. And they are worse after sporting activities, and they can have continuous pain. From a treatment perspective, these are self-limiting conditions. They tend to heal over a period of time. You can use ice after activities. Modify activities means, prevent them from sports or jumping for a short duration. Physical therapy can help NSAIDs, and we use a Chopard strap, which is shown here on the right side. We don't tend to use immobilization or cast for Osgood skeletals because it can lead to weakness and atrophy. But some form of restricting activities would help. As far as therapy is concerned, anytime you have tendinitis, an eccentric form of exercise would help, whether it's patellar tendinitis or whether you have golfer's elbow or tennis elbow. So the difference is, for a concentric exercise, when you're pushing, the muscle contracts and it shortens, and that pulls and it tears structures. So what you need to do is bring it back, the weight, instead of pushing it up. So you can push with the good leg and bring it back with the involved leg, and that lengthens the muscle with force. It's excellent for tendinitis. Shin splints is the medial tibial stress syndrome. It's very common after running activities, or those who are doing a lot of increased activities. You can get shin splints, and then you need to differentiate that from stress fracture. Shin splints, the patient would not point with a finger like this. Shin splints is a pain over a longer or generalized area. Like you see here, a little bit lower along the medial aspect of the shin, where the muscles insert. And when you have focal pain, it is most likely a stress fracture. So you need to differentiate that. You can use X-rays or MRI to differentiate that. They are treated differently. When it is shin splints, you stop your activities, then stretching of the lower leg muscles. Sometimes you need arch support, NSAIDs, and gradual return to sports. And there could be recurrences as well, so you need to have a gradual return to sports program. Whereas for stress fracture management, you need to shut them down completely. That means you either use a cast or a boot. You can use crutches if they're limping, or if they're more pain, limited weight bearing. No sports till the fracture is healed. In the case of a 9-year-old boy who plays soccer, runs track, and plays volleyball, has a recent growth spurt and complains of bilateral heel pain. So we come from the knee down towards the heel now. And the diagnosis is just based on history. If they are having pain around the heel, it's Sever's disease, which is calcaneal epiphysitis. And you don't need an X-ray. If you take an X-ray, it cannot tell you whether the patient has Sever's or not, even if you have fragmentation. It's a normal process of ossification that you can see fragmentation along the calcaneal epiphysis. The etiology is overuse, poor shoe wear, pes planus, some tightness along the Achilles, and that's why the treatment is stretching. They present with heel pain. It's bilateral in 60% of the patients. They could have had recent growth spurt, and they have pain first thing in the morning. And the treatment is crutches or immobilization if they have significant pain, but usually Achilles stretches is what helps the most. You can use some gel pads, and you can use better cushioned footwear, ice after activities, and some NSAIDs. So, when all these apophysitis, Sever's conditions, or Osgood, once the growth plates fuse to the main bone, then you don't see the problem. So that's between 13 and 14 years of age in boys. So it's a self-limiting condition. Once there is no apophysis, then there is no pain. Gymnasts, they load their wrist and they can get distal radius physis stress reaction. They can present with wrist pain. And again, avoid loading the wrist for 3 to 4 weeks. Symptomatic treatment, you can use you can use a brace or modified activities. Same with little league shoulder. Those who are throwing quite a bit can have widening of the proximal humerus physis. And you can see here they need rest for about 3 to 4 weeks. And the thing with the pitching is that they need to have some rest days. They need to count the number of days. The coach needs to be aware of the pitching regulations, how many pitches they can throw and how many days they can throw in a week. So you need to avoid pitching for 3 to 4 weeks, and that would heal. And then you may have to do some physical therapy to stretch the tissues around the shoulder. The last is OCD, or osteochondritis dissecans. Now, this is a cavity in the bone, and for this one, you do need to refer these patients to ortho. They can have cavity in the talus. They can have it in the knee, in the capitulum. The symptoms are pain, swelling, or catching. Typically seen on X-rays, but we do get an MRI to evaluate the articular surface. When you get knee X-rays, we always get 4 views of the knee: AP, lateral, notch, and merchant. And the reason is that you can see on the AP view, everything looks okay. But when you take a notch view, which is taken with the knee in about 30 to 40 degrees of flexion, you'll see the posterior aspect of the knee joint. So you can see that when you take a notch view, and the reason you know it's a notch view because you can see the notch very well. But now you can see that on the lateral femoral condyle, there is a big cavity there, and you didn't see it on the AP view. So the notch view is very important. And if you don't take a notch view, you can miss important things. And same with the merchant view, which is the axial view of the patella. If you have a patellar OCD, then you can only see it on a merchant view. This is an example of the patellar OCD. You can see it on the lateral here, but the merchant view would show it even better. This is an MRI, but you can get an OCD of the patella as well. This is the arthroscopic image of how it looks. It's like a blister that's opened up on the patella. When we open it, we cleaned it up, you can see the cavity, and this is an arthroscopic evaluation of another cavity of the medial femoral condyle. And you can see it looks okay from the surface, but when you take a probe and when you try to pull on it, you can see that it opens up like a hinge door. And this does require advanced treatment. We fill it with bone graft, put it back, fix it with screws. Sometimes we'll patch it with cartilage from other areas of the knee joint, and sometimes we have to use cartilage from a cadaver or an allograft. So depending on the size, depth, and the amount of area that is affected, the patients need different types of treatment for OCD. So these are usually treated surgically if they're unstable or they're in advanced stages. If they have open growth plates and they're stable, then they can be treated with a cast or modified activities or offload or brace. But if they're unstable or they're adults, then they need surgery. This is an example of it being fixed with an open procedure. A few slides on prevention. So general strategies for prevention of sports injuries: make sure that you have a coach who understands the importance of warm-ups, stretching prior to doing sports, conditioning prior to sports, protective equipments, and all equipments are in good order, and then sports specific prevention. There are no conclusive studies on use of bracing or taping for ankle injury prevention or for bracing for ACL injury prevention, but they can be used if psychologically, if it's helping an athlete. No harm in using any of the bracing or taping to prevent injuries. There can be sports fatalities. For head injuries. It's always recommended to use helmets in contact activities. cardiac events like hypertrophic cardiomyopathy, which is the #1 cause of death in athletes less than 35 years of age. You need to make sure that you can screen them, and heat stroke, it could be prevented by hydration and education. So in summary, sports injuries are common and increasingly recognized. Acute injuries are treated using Rice principles. Shoulder and patellar dislocations may need surgery. Overuse injuries are treated symptomatically with relative rest. Prevention should be emphasized. And this is the slide which I had shown initially, all the resources doing OrthoBullets, ViewMedi, and the NCYS, which has a Stop Injury Prevention program. So if you want to use any of those resources, then that would be helpful. Thank you.
Thank you. Thank you, Dr. Parekh, for such a nice summary of all these sports injuries. And I wish we had known more about these in the medical school. As you mentioned, not many of us are exposed to any of this. This time I'll have Dr. Indranil Kushare step in and moderate the session. Thank you.
Thank you. Thank you,
Thanks.
Dr. Govind. Thank you, Dr. Govind. Sorry for the late join. I'm still trying to work on getting this camera going because it's asking me to restart the computer. But great talk, Dr. Parikh. We have multiple questions. So let me start off with Dr. Gupta is asking whether the effectiveness of PRP in ligamentous injuries, where do we stand?
That's a great question. So PRP, as well as other products, biologic products like stem cells, they have all been used, but there is a big hype around it. One is they are expensive, they are not regulated, and they are not scientifically studied. So the only conclusive evidence we have about use of PRP is in moderate arthritis, where it has shown to be effective for the knee joint. Rest of the conditions, including tendinitis, as well as to make any torn structure heal, we don't know the correct dose. We don't know the formulation. We don't know how many injections. And there are so many different types of PRP, but it's such a big market because every street now has a shop that's going to give you PRP. We haven't done much with PRP in kids because we don't know about the safety. So at Children's Hospital, we are not using it. But as far as the academy is concerned, or the academy statement on PRP is that it is okay to be used for arthritis, but not for any other indications.
Great answer. And then secondly, microneedling for healing for muscle and tendon injuries. What are your views on that?
So, it is typically done by a trained physical therapist or an athletic trainer. I've seen patients having some benefit, especially when they have, we don't have answers to every pain that a patient may have, like in orthopedics, in pain management, or in sports medicine. Which means that if there is a pain because of a muscle issue or pain because of a nerve that's getting stretched, everything cannot be treated with surgery or with bracing or with physical therapy. So then we try alternative medicine, and I have nothing against alternative medicine. If there is no, I would say cure. If there is no cure, then alternative medicine might be useful, and needle therapy or acupuncture would fall in that category, though it's a little bit different, both of them. But needling is done for a lot of tendon injuries, and I would just say I've not seen any harm from a patient having needling. So I'm okay if a trained therapist or a trained athletic trainer is doing it, I'm okay with it.
Thank you. In what conditions do you assess, which injuries would you recommend doing a high resolution MRI, like a 3T or above MRI? Any specific injuries?
I would say, if possible, get a high resolution MRI. Nowadays you have high resolution MRI at almost every center. It would not matter too much if you're doing an arthrogram. So say, for example, you're doing a shoulder MRI with an arthrogram, it would not matter much because when you have an arthrogram or a dye in the joint, that is significant contrast. But for all other things, like if I want to see cartilage, if I want to evaluate OCD, if I want to see the meniscus, nothing beats a high Tesla MRI. So if you have to order something for an orthopedic condition, I would recommend go for a high resolution MRI.
This is Dr. Vikram Paul. He asked whether you see more ankle injuries or more knee injuries in children's doing sports, and also he would want to know a little more about the preliminary pre-hospital management for non-orthopedic MDs like splinting.
Yeah, that's a good question. So, our practice is a little bit skewed because we don't see patients that have relatively minor injuries, I would say. If they are treated by the trainer on the sideline or primary sports or by the primary care physicians, then they won't end up in an orthopedic clinic. So if I look at my clinic, I see more knee injuries because they are more surgical injuries or surgical lesions compared to ankle injuries. But if you look at the epidemiology overall, then ankle injuries are more common than knee injuries. And the second question was prior to presentation. So splint is really useful, and depending on where you are when the injury occurs, most of the trainers on the sideline, they have some sort of splinting material. The idea is that you don't want to wrap it too tight. You want to make sure that you splint in a very functional position or a relaxed position where the patient is comfortable. And if it's a lower extremity injury, make sure that they have crutches. And if it's upper extremity, maybe a sling. And then you transfer these patients. It's a good question. And, a lot of times I've seen that the trainer would reduce the shoulder or the patella on the field, which is okay. If it's patella is fine because it goes in very easily. For the shoulder, sometimes if it's recurrent, like if it has happened few times, then it's easier for it to relocate so that, they can reduce the dislocation as well on the field. But for other injuries, I would recommend splinting in a neutral position or a functional position, and don't put a tight A strap or anything tight around the area of injury.
Thank you, Dr. Parikh. And then Dr. Anuj Sharma is asking, bodybuilding has its own common low back injuries, be it muscle spasms leading to loss of lumbar curvature or adductor tendonitis in the leg. What would be the initial intervention at the sidelines, and what is the criteria for its orthopedic referral?
That's a good question. So one is that, if you consider age-wise, then, kids should not do any bodybuilding because the memory doesn't start building up till puberty. So anyone less than 10, 11 years of age should not be, doing any bodybuilding because the muscles won't remember. For an adult doing bodybuilding, the reasons for referral would be acute tears, like if you have a pec tear or, any tendon that is completely torn, which is, you'll have a deformity and loss of function, that needs to be referred because that's all surgical. If they have pain, that is when it can be treated non-operatively. So tendinitis or even muscular pain in a bodybuilder, you may need to rest them for a few days. And then the eccentric exercises that we talked about, because those are great for tendinitis. So maybe having a physical therapist getting involved in their rehab, and then using anti-inflammatories and muscle relaxers for symptomatic treatment. It usually takes about 3 to 4 weeks for their acute pain to resolve, so you might have to restrict them for that long.
Thank you. I think I have one more from Shwetang Shah. Hello, Dr. Parikh. Do you have any recommendations for refreshing splinting and casting procedures for primary care providers who frequently manage sports injuries?
Yeah, so I mean, if you're going to use it tentatively, then orthoglass is okay. Orthoglass is like pre-made splints. You just have to cut it and put it on and wrap it with an A-strap. They shouldn't be used for more than 3 or 4 days because it leads to, pressure injuries. So, but orthoglass material is good. If you are familiar and if you can use the casting materials like a plaster or a fiberglass, then that's great. That's what we use if you have to use it for a little bit extended periods of time. But typically splints are used for temporary purposes. More permanently, if you want to treat something with immobilization, you treat it with a cast or maybe a removable splint, not an orthoglass or a plaster splint. Now, there are some, it's a good point because it's very difficult to learn splinting just by reading. And, there are some workshops. We have some videos on splinting. And, if needed, if there is a place to post them, I can post like a half-an-hour video on all different types of splints and casts, how to put it on. And I'll talk with AAPI, and if they need anything, I can put it up on the website, or maybe you can email me and I can send you a link to splint and cast. I think because it's easier if you see it rather than you read about it, and it's even better if you can do it. So we do have some residents and some family physicians who would come in our fracture clinic, because we have a cast room, we have cast technicians. And there are 7-8 cast technicians working at the same time. So in like half a day, you'll get good exposure to different types of splints and casts.
Thank you. Probably one last question by Dr. Malti Vij. At what age kids should start formal exercise and strength training?
As I said, it's after the age of 10, hopefully after puberty, if you're talking about strength training. But they can get involved in early on in, just stretching exercises and doing sports. The important thing is to not focus on a single sport specialization. Like when they were interviewing all the Olympic athletes, they started concentrating or focusing on one sport after puberty, after the age of 14. The rare instances where you see like, the Williams sisters who were started at young age, and, Agassi who started young age, those are only a handful of examples. Most of the kids or most of the athletes were playing multiple sports till the age of 13, 14, and then they focus on one sport. So I would just recommend, if your kid is getting into sports, they should be doing multiple sports. That way you can, cross-train the muscle groups rather than sticking to one sport, because that would lead to, injuries, overuse, fatigue, burnouts, everything. So multiple sports, let them also have some free play. And then after 13 or 14 years of age, they can focus on one or two particular sport if they like.
Great answer. Thank you. I think we're done with questions, and it's 8 o'clock also. Dr. Govil, I will have you take over.
Sure. No, thank you. Thank you, both of you. And I'll have Dr. Katula.
Thank you, Sheetal. Thank you, Dr. Kushare, for this wonderful session. And thanks, Amit, for arranging this. And we have a virtual plaque presentation. And I would like to invite Dr. Sunil Kaza, the Chair of Board of Trustees of AAPI. Dr. Kaza, could you present the plaque to Dr. Parikh?
Sure.
Thank you.
American Association of Physicians of Indian Origin recognizes Dr. Sheetal Parikh for his outstanding contributions in the field of orthopedics and welcomes him as a member of AAPI Distinguished Speaker Club from Satish Katula and Amit Govil, Chair of CME Committee, on this April 30th, 2025, from Central AAPI office, Oak Brook, Illinois. Thank you, Dr. Parikh.
Thank you very much. Appreciate that.
Thank you, everyone. Yeah. We look forward to the next webinar in next 2 weeks. We'll send the update, and we'll looking forward to seeing many of you at our AAPI annual convention in Cincinnati, July 24th to 27th. And Dr. Katula has it all lined up for everyone. Please join us.
Thank you, Amit. Thanks, everybody, for joining. Thanks, Sheetal, again. Thank you, Dr. Kushare. Appreciate everybody.
Thank you.
Thank you.
Okay. Bye-bye.